Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach, and this is another episode of Dadvice TV Live. Now, for those of you that are new, my name's James. I have kidney disease. I've had it now for about 5.5 years. Didn't look good when I first got it, but I have worked on diet and lifestyle changes to help me live better and live longer while I happen to have kidney disease. Now, tonight, I've got an amazing co-host. You guys all the regulars, you all know him. You all love him. You get so excited. And I'm going to bring him on in just a minute. And we are going to talk about your kidney labs, something that you get often. The lower your kidney function gets, the more often your doctor may want to get labs from you. Understanding your labs is really, really important. And once you've done them for a while, you'll know what to look for. We're going to help you. We're going to give you the shortcut on what's important, what things mean, and what to watch out for. Now, my co-host has written an amazing book that I wish when I was diagnosed, my doctor would have handed it to me instead of saying, hey, we need to start talking about dialysis, because it's been 5.5 years. No dialysis, no transplant. I still got my bad kidneys, and I am doing great. But his book is called Learn the Facts About Kidney Disease. It's easy to read, easy to understand, and all the things that you worry about when you're first diagnosed, Dr. Rosansky addresses those. You are not going to worry anymore. You can pick this up at Amazon. Your local bookstore may have it, or they can at least order a copy in for you. You can also go to go.dadvicetv.com/book. But this is a wonderful and fantastic book. And I know a lot of you out there watching now already have his book. You've read it, and you can attest it is easy to read and very, very helpful. My allergies are kicking up a little bit today, and I got a cough drop in. Sorry about that. It makes me kind of get tongue twisted every so often. But let's bring on my co-host, Dr. Stephen Rosansky. Hey, Doc, how you doing?
I'm good, James. Always good to be on your show. Good evening, everybody. I know we got a little competition coming up at about 9 o'clock. There's the first presidential debate. And I hope that you guys will learn a little bit more about kidneys before you learn more about politics. And good luck to the debaters. And we'll leave it at that. We won't discuss politics. Too
Very
controversial.
Now,
Way
for those
too
that are
controversial.
watching, tell them a little bit about your history so they know why it's important to take what you say seriously when there's so many people out there spreading false information about kidney disease.
Yes, I am a retired kidney specialist. I actually still see patients. I saw them yesterday in the free clinic here in Columbia, South Carolina. And I've written many different publications with my colleagues, about 100 peer-reviewed publications. And I started the kidney program here in Columbia, South Carolina at the VA. And I had a 40-year career there, taking care of hundreds of patients with kidney disease. And I also have published a good deal about the issue regarding what affects the decline of kidney function, how to slow the decline of kidney function, and most importantly, for those of you who have been told that you may be close to dialysis, my research has been widely acknowledged as being very important because it basically has shown that many people were being started on dialysis way too early, and which is one of the reasons why I wrote my book, to hopefully get to the patient and let them discuss with their doctor what is an appropriate time to go on dialysis, not to start too early unnecessarily, because some people, if they're especially older folks, may never need dialysis if their dialysis is appropriately timed. So, and then the other thing that we've talked about a lot is a lot of you folks have early stage CKD, and the likelihood of going on dialysis or ever needing a transplant is extremely low. And we'll discuss some of that tonight. We always do mention it. But actually, the topic tonight came from one of your questions, and I encourage all of you to give your questions. I'll get to as many as I can. We'll get to as many as we can. And, if you've got something that's you would like this discussed on James' show, Dadvice TV, we may pick it up. And one of your questions was, what about my labs? And that's why tonight's show is going to answer that question.
Perfect. We have lots of people telling us where they're from. They're all over the place. And Doc, I wanted to tell you one piece of feedback I got. I have an email I want to forward you from one of our people who watched last month's episode, when we were talking about kind of all the scams out there and things to avoid. She was taking one of those scams, and her doctor was saying, don't take that. But she continued until she saw our show. She stopped taking it, and she actually was not feeling well while she was taking it since she started. And she says now she's feeling much better, and her doctor is very happy she stopped taking a fake herbal cure.
There are so many out there, and anything that I talk about has been reviewed. It's scientifically based. It's from anything that goes out to you folks that I discuss has extraordinarily complex methods to get into written form. We call them publications, written articles. And these studies are very, very, very hard to do. And I'm coming out with the information from these studies and giving you the latest about what really might help you. So let's get right into your labs. You ready, James? So I want to answer some questions. I know we never wind up
We
having
are
enough
ready.
time. Okay. So we go back to something we talk about every show almost. Your kidney number. Excuse me. Your kidney number. What is it based on? Your estimated glomerular filtration rate. James, I'm going to test you as usual. What does the kidney number depend on?
It is an estimation of your kidney function using the amount of creatinine, which is a normal waste product your muscles create that's in your bloodstream. And creatinine is not bad. When you first get diagnosed with kidney disease, you so want to get rid of creatinine, but that is the wrong path to go down. I had to throw that in, Doc, because we all get stuck chasing that. How do I lower creatinine?
Nonsense. It's nonsense. Creatinine is just a marker, and it just happens to be something that comes from your muscle. Your muscle produces something called creatine. It's the engine of muscle work. And that creatine is metabolized to creatinine, and it depends upon the amount of your muscle mass. That's how much creatinine you produce every day. And if your kidneys are working normally, that creatinine is peed out every day. And as your kidney function declines, that creatinine number will start going up.
And it barely goes up. It goes up just a tiny bit.
Exactly.
And your kidney function, the estimate, changes a lot.
Exactly. You got it, James. So the normal range of creatinine in the United States is 0.7 to 1.3. So if you're in that range of normal, or if you go up from 1.3 to 1.4 or 1.2 to 1.4 or something like that, there could be enormous changes in that number you get from an equation, the estimated GFR equation. Outside of the U.S., and this is going to confuse people because not everybody gets the U.S. units, it's in units that you have about 100. You divide your units, which are given in micromoles per liter, as opposed to our U.S. units is milligrams per deciliter. If you got your labs, you could work with us tonight and look at your lab sheet. So outside the U.S., the range is 62 to 115. It's basically divide that by 100, you get close to what our units are. Now, The estimate of GFR. Why do we say it's an estimate of GFR? And what is the equation that's estimating your kidney function? What is it trying to adjust for?
It's trying to adjust for a lot of stuff.
Right.
It's a
What's the
long,
main
and
thing?
and it changes every so often. They update it.
Right. But what's the main thing that they're adjusting? We just said that most of the creatinine, that's the lab value that determines your eGFR, your kidney number, it comes from muscle. So
Right.
what do we have to adjust? We have to adjust for the fact that different people, depending upon your age, probably your race and your sex, will have different amounts of muscle on average. So
Right.
the equation is going to adjust for that. Okay.
Or
And the
try
other
to.
thing is it tries to. And it's not exact. Don't put your finger on my eGFR is 54, and if it's 50, and if it goes down to 53, I'm going to be worried. It is a estimate, a serious estimate, and the estimate can vary by a lot from one test to the other. And that's why you need multiple levels to mean anything. And as James just said very correctly, if your kidney function is close to 60, that means your creatinine level is close to the normal range.
Mhm.
And a little bit of change can make a massive difference in that eGFR. Thus, labs became smart, and instead of getting people all worried and going crazy, they said, we'll only report, most labs do this, when it's below 60. If it's above 60, they just say above 60. That's the smart way for the lab to report your eGFR.
Yeah, and I wish
Um,
they would change from an exact number to a little range,
yeah,
since your GFR can fluctuate throughout the day, and I think that would help a lot of kidney warriors not worry as much from those small changes that are normal.
exactly, exactly. So that just kind of run through a couple of things. We've discussed this in detail on some of the other shows. Things that can change that creatinine value and therefore your estimate of kidney function, eGFR. GFR is glomerular filtration rate. What does that mean? Each of us has about 1 million of these little tiny filtering units in each of our kidneys called glomeruli. So when you take all of those couple million of glomeruli and have them all filter, you get what comes out as a filtrate and eventually your pee. That's your glomerular filtration rate, just so you understand what we're talking about. Now, if you eat a lot less protein, and a lot of people push it, and I've discussed this many times, I am not an advocate. As a matter of fact, I am strongly against very low protein diets. And we'll get to that a little bit today in one of our lab values. You folks that are on these very low protein diets, you are doing yourself harm. And there's only one situation where I personally think it makes sense. There's a lot of other things, which we'll mention again, as we always do, that can help slow the decline of kidney function. You don't want to take in a high protein diet, but there are books and there are people that advocate very low protein diets with expensive keto supplements to supplement the amino acids that you need to make proteins. I'm totally against it. If you are young and you're losing kidney function quickly, the only time that I would even consider it. Otherwise, there's other things that you should be doing, not very low protein diets. So in order to compare your values, you can't have switched to a very low protein diet because that's going to give you, guess what? You'll have less muscle, right? When you have less muscle, what happens to your creatinine?
It goes
It'll go
down.
down. And that creatinine, this is a little bit of math, is in the denominator of the equation that determines your kidney function. And if the denominator goes down, the value goes up. So it'll look like your kidney function gets better, but you're actually sicker. Your chances of dying prematurely are increasing. You may have malnutrition, and you may think you've done something for your kidneys, but no. You just basically got rid of muscle and you're not doing yourself any favor. Okay. So you need a stable diet, stable muscle mass, and state of hydration. Sure, you could drink gallons of water and dilute things in your blood, and that, again, will lower your creatinine, which will raise your GFR. It's pointless. Don't try to do that.
You're just lying to yourself.
The only time that I strongly advocate drinking a lot of water, I mean, we all need to drink in the hot weather, for sure. Don't get dehydrated, especially anyone with kidney disease. You get dehydrated, your kidney function could go down very quickly. Stay hydrated. Stay hydrated, especially older folks. You're in a lot of heat. You're not getting enough air conditioning. Please stay hydrated. Common way to get your kidneys to really look bad and kidney function to go down. So you need to have good hydration, especially independent of the heat if you have kidney stones. If you have kidney stones, you should be drinking a lot of water. Other than that, you don't need to drink a lot of water to help you with regard to losing kidney function. No one's demonstrated that you drink a ton of water that's going to keep you from losing kidney function. But stay hydrated. Okay. Now, I will mention it. We always mention this. What if your kidney function, when should you not, okay, how do I put it? There are certain drugs that you can take that can drop your kidney function when you first start them. Mm-hmm. And these are the drugs that may, in the long term, slow the decline of your kidney function, okay? And these drugs are James is going to spout them out. Go ahead,
the ACEs
James.
And the ARBs.
Yeah, tell me, how do you identify them by the generic names?
They end in prin and pril, and you only take one or the other. You don't take an ACE and an ARB. It's one or the other. And some of the best things about them are they're cheap and they're widely available.
You almost got it right. The prils are the
I just couldn't remember which one was a pril and which was
no, that's okay. No, the prils are
the
ACEs like captopril, enalapril, lisinopril. The TANs are the ARBs, losartan, candesartan, okay? Basically, you take one or the other. Yep. The other drugs, and so when you start these drugs, you can get a drop in your estimated GFR, your eGFR, your lab number, by up to 30%. But in the long run, they are probably important, especially if you got what, James, in your urine?
Protein in your urine.
Yeah, if you've got a good bit of protein in urine, these drugs are important, and they should not be stopped even when you have an initial decline. There's other newer drugs. You know the kind of classes of the new drugs, James? Can you spout them out?
SGLT2s.
Right. The SGLT2s were used for diabetes, and they're great drugs. They can slow decline of kidney function, and they can decrease your deaths from heart disease and heart failure. Great drugs. And the other one?
GLP-1s.
The GLP-1s are the weight loss drugs. I refer you to other talks about how to slow decline and what to do about people with proteinuria. And then the last type is what you're on.
It starts with an A. It's 2 words.
Okay, so aldactone. Okay. Okay, so you are on spironolactone. You're on spironolactone.
Correct.
So it's an aldosterone antagonist.
That's it.
Aldosterone antagonist. What it is, aldosterone is a hormone that works on the kidney to get you to get more sodium back into your blood, which will actually raise your blood pressure and excrete potassium, okay? And those drugs may also slow the decline. Now, and so starting any blood pressure medicine when you're got lots of you folks who have had a lot of fluid in your body, and you had your doctor take off 10, 20 pounds of fluid, you expect your creatinine to go up because it was diluted. That doesn't mean that your kidney function really changed. It just means that you're really showing what your actual function was. So diuretics can do it as well. Mm-hmm. Now, what are the stages of CKD mean, James? Do you know what they mean?
Well, I know what the 5 stages are, 6 if you count 3A, 3B, but they start at 1, which 1 and 2 are above an estimated function of 60, and then the other ones are closer to, or it's reduced kidney function as it goes closer to 5. And then stage 5, which is 15 points, is where the symptoms start to show up for most people. Most people, it doesn't show up until so late, which is why it's considered the silent killer or
I agree.
silent disease.
I agree with just about everything. I think there's two corrections. So let's start from the top. We used to have people worry, oh, I'm stage 1, I'm stage 2, my eGFR is 80 or 70. We don't worry until it's 60 or less. And it's got to be in 3-month interval. Just because you got a 60, you got a 60 on your doctor's report on your lab value. Don't worry. You'll come back 3 months later. A good percentage of you will be above 60, so you will not be declared as having kidney disease. You want at least 2 values over 3 months less than 60. And basically, the stages, you can love them or hate them. I hate them, frankly. It caused a lot of people to worry, caused a lot of people to go on dialysis early as well. Those stages, everybody getting a kidney number and obsessing over the numbers, and then the doctor's plugging you into a dialysis machine when you didn't need it. Started in 2002. We got a lot of people saying, let's use this equation to get your estimated kidney number. And then it's been, kind of, in my opinion, downhill ever since. and so the initial thing was 5 stages, depending upon your number. The latest, let's forget about the over 60, other than when is your number over 60 of importance, James? In what situations?
When you have another sign of kidney problems like protein in the urine.
Right. And I'm going to tell you what's the next topic, what is a significant level of protein in the urine? If you have a significant level of protein in the urine, even though you're over 60, you got kidney disease. If you consistently have protein in the urine that's of significance, and your estimated kidney number, eGFR, is over 60, you do have kidney disease. Okay. Now, how do you measure the protein in the urine? By the way, before we get into that, the recent stages have moved away from just the number, the eGFR number. Why and what is in the new way to stage patients, James?
Remember? It is the proteinuria, the protein in your urine, and that's a big indicator of future problems.
Right. So the way they have like a heat map, and if you've got, as your kidney number goes down, your risk of having troubles increases. And as your kidney number goes down and as your protein number goes up, that's when you get more risk of having to worry about going on dialysis or needing a kidney transplant. And most importantly for most of you, because the majority of you will never get to need a dialysis machine, but you're going to be at higher risk of dying from hardening of the arteries. I won't ask you to say the word. It's called atherosclerotic.
All the regular viewers know I can't say that word.
Atherosclerosis. Hardening of the artery, which leads to heart attacks and strokes and chest pain and heart failure. So that's why if you have real kidney disease, by things we're talking about tonight, and we've talked about it in other shows, your risk of getting a complication from hardening of the arteries goes up. So you need to do the appropriate thing. You measure urine protein. The best way is what, James? And people still haven't gotten it.
In your urine, and the test is called ACR, Albumin-Creatinine Ratio.
Perfect.
Boom!
Albumin is one of the proteins. We used to measure all the proteins, but we try to be consistent. So instead of measuring all protein, we measure the most important protein, which is on your lab test, and I'll get to that later. Is called albumin. So the lab test that you do is a tiny drop of urine, and you send to the lab, and the lab will measure the albumin in the urine and the creatinine in the urine. And of course, being the U.S., we have different units than the rest of the world. Our units are milligrams per gram, milligrams of albumin per gram of creatinine. Outside of the U.S., you divide the U.S. numbers by 10 because you have milligrams per millimole, just to confuse you all. So, abnormal in the U.S. is 30 to 300 on the albumin-to-creatinine ratio. Outside of the U.S., it would be 3 to 30. Over 300 in the U.S., that's a lot of protein. If you have an albumin-creatinine over 300, even over 200, I'd say you got a lot. And the same for outside the U.S. would be over 30 or over 20, okay? Just like urine, just like GFR, just like your estimated kidney number, repeated values are necessary because the amount of protein can vary from one visit to the next. So you want to get multiple values. And as we said, as your kidney number goes down and as your protein goes up, higher risk of either getting kidney failure or getting one of those bad events from the blood vessels. Now, most of you are going to be 30 to 60 with minimal protein. So 30 to 60 is so-called stage 3, when your number's 30 to 60 in that range. And as James said earlier, he's right on it. There's two groupings now, which is 3A and 3B. What is 3A, James? You remember?
3A would be 60 to 45, 45 to 30 is 3B.
45 to 30 is B, right. Perfect. Yep. Okay. Now, here's something that my colleagues in Australia and New Zealand make me very happy about. And it gets to the issue of so many of us older folks, like me, I'm 77. When Australia and New Zealand said if you're over 70 and you have a normal albumin-creatinine ratio, when did they say that your GFR is normal? Over what value?
Over, I can't remember for sure. Was it 60 is normal? Well, 60 would be normal, but isn't it lower?
45. They say if you are an older person and you don't have protein in the urine and your kidney number is over 45, not to worry. You're probably not really having kidney disease because there is an age-related decline in kidney function. And the vast majority of you folks out there are between 30 and 60 without a lot of protein in the urine. And the chances of going on to dialysis or needing a transplant are going to be about 1 to 3 in every 1,000 patients. Not real high, okay? Not impossible, but certainly not real high. And we talked about the people that have significant protein by the albumin-creatinine, or we're going to get to the dipstick in a minute, because that's another lab test that I want you all to know about. I'll just mention this because it is important. James talks about his lifestyle, and I think James got the message. The message is, if you're like James or anybody else with real kidney disease, your GFR is below 60 or below 30 or, certainly, which would be stage 4. Stage 4 is 15 to 30. Stage 5 is less than 15. And by the way, they call stage 5 kidney failure, which I am enormously against, because that people assumes they need to be on a machine. Hell no. You probably could go years below 15 for many of you without ever needing a machine. You may be able to wait till you're 5 or less on your number. Okay. Other labs. What is the BUN, the BUN, James? You ever hear that one?
Oh, yes. Your BUN, your blood urea nitrogen.
Is that a good measure of kidney function?
I don't think so.
Absolutely not. It is not a good measure of kidney function. It used to be, in the old days, And for some of the old doctors, I hate to use this term, but they used to call them the Gomer doctors, the old Gomer pile doctors that are not up to date, may still think that they should look at your BUN. If you're smart enough, you could look at your BUN and the creatinine, the one that really matters. The creatinine is the one that has some real value in determining kidney function. If you look at that ratio, it could tell you a lot of things. It could tell you whether you're dehydrated, because that ratio will go up. It could tell you if you're bleeding. It could tell you if you're on a high protein diet, your BUN will go up. It could tell you if you have liver disease, your BUN will go down, because the liver makes that urea nitrogen. And if your doctor's talking about your BUN, your BUN, as a measure of your kidney function, go find another doctor. He's not or she's not informed.
I can tell if I eat a bunch of if I was to eat a bunch of steak right before my labs for a week, my BUN would be high, and if I go vegetarian for a week, it's normal.
Exactly. So BUN is affected enormously by diet, enormously by state or hydration, and people. This is one thing that's those of you who are unfortunate enough to have really bad heart disease. I've seen people with a BUN. The normal value is 10 to 20. I've seen people with BUNs of 200 with a creatinine that was not much above 2. So so you can't go by the BUN for sophisticated people who understand how the kidney works can give you information, but it's not a way to measure kidney function. What about the dipstick? Because you folks are getting lab work, you're going to get a urine dipstick. What's on the dipstick? It's got, James, if you happen to know?
Well, it does 7, at least the one I use is 7 and 1, but the one I look at is the gravity to make sure I'm not, over hydrated. And then it has a number for protein, or
Good.
It gives you a protein.
Okay. So James is talking about something called SPGR, specific gravity. All that's telling you is if you got concentrated urine. The higher that number, that means it's more concentrated. The reason why we've moved to that spot urine that measures the albumin in the urine and the creatinine in the urine is because your urine analysis is going to be greatly influenced by whether you've had a lot of drinking or you've had minimal drinking. If you're dehydrated, your urine protein dipstick value could be a lot higher. And if you dilute it out by drinking a lot, it could be a lot lower. So that's why the spot albumin-creatinine is much better. But it's a screening. And as I mentioned on other shows, you can buy these dipsticks on Amazon. And those of you who want to follow your urine protein, it's not a bad idea to periodically check it, especially if you're on some of these medicines that you're hoping will lower the urine protein and in turn will slow the decline of your kidney function. The other measures on the dipstick are blood, which is part of kidney problems. So people with kidney stones, sometimes menstruating women will have blood in the urine, but some kidney disease will cause blood in the urine. It's not the one we focus on. We focus more on what James said, the protein, dipstick protein, which we'll get to. The other things on your dipstick are something called nitrite and leu esterates, which the nitrite on the dipstick and the leukocyte esterates are indicators that you may have a urinary tract infection. If those two things are showing positivity, leuase or nitrite, you may have a urinary tract infection. And those of you who have these dipsticks and you have burning in your urine, I just checked my daughter-in-law the other day. They were both positive. The nitrite was positive. The leuase was positive. She's going to go and get a urine culture. What is significant protein on the dipstick, James? What would you say?
Is it 3 and above?
Okay, it's trace. Trace is not.
Trace.
No, trace is not significant.
Okay.
Trace can be not significant. 1+ is consistently 1+ is going to be significant. Why? Because it means you've got at least 500 milligrams of protein. Remember, we said 200 to 300 is a lot. So if you're consistently 1+, you've got a problem with urine protein. Now, when just real quickly, back in the days in 2002 when I was practicing, or these stages came out, we were getting all these people referred to nephrologists. We were overwhelmed because everybody had an abnormal eGFR. Oh, what's your kidney number? Oh, I'm so worried about it. It's 70, it's 80, or it's whatever. And they started sending them to nephrologists. When do you think, you folks out there, James, do you think any of your viewers should be followed by a nephrologist? What stage would you say?
So I would say definitely stage 4, maybe 3B if you have protein in your urine, if you have other serious issues. And what, from my experience, my nephrologist was helpful in educating me, but there's really not, there was no magic pill. I was hoping to go in there and get a magic pill and all of a sudden things would be better.
Right. Well, you're right, James. And basically, nephrologist says if you're stage 4, which is less than 30, you need to start being followed by a nephrologist. But I would agree with James. If you either way, if you're one of these people that has a lot of protein in the urine, I would say you should be seen by a nephrologist, because sometimes we need to do something called a kidney biopsy. And we do that with people with a lot of protein in the urine. I'm talking about 1,000 milligrams and above, 2,000, 3,000 milligrams of protein. Remember, we said over 200 or 300 is serious, but when you get up in the real higher range, your kidney doctor is probably going to want to do a biopsy. And you're right, James. I'd agree with it. And when is dialysis? When do you start needing to start considering being prepared for possible dialysis or a kidney transplant? At about what level, James?
So I would plan on starting dialysis around a GFR of 5 when medication cannot control the symptoms and stuff. So which is, it's most likely going to be around then. For me personally, probably I'd wait till like 10 to start planning for it, but it depends on the trend, how quickly I'm declining.
Right. But I would say it is reasonable for those of you who are consistently 15 or less. Look at my book of the factors that you need to consider about the options for you in terms of transplant options, how to deal with that, in terms of dialysis options, how to deal with that, and in terms of when it makes sense to start dialysis, if ever. That'll be when you're in that 15 or less ballpark consistently. All right. What about getting on the transplant list in the U.S.? What level of GFR do you need in the U.S.?
I believe it's 20 or less.
Right. And if you are someone who wants to be eligible for what's called a cadaver kidney transplant, of course, you want to get one from a relative or a friend or anybody else who's willing. But if you want to get on the list for a non-related person, get on as early as possible, and you are eligible to get on 20 or below. That's what you need to know. We'll discuss some other lab values. What about CBC? What is that, James? Do you know?
The CBC, isn't that the test? Yeah, that's a full panel, isn't it? A CBC?
No. Oh. CBC. It's a complete blood count. Simply meaning your red blood cells, right? And your white blood cells. Okay. As a kidney patient, you focus on the red blood cells. And what part of the complete blood count, which measures everything to do with red cells and white cells, do you focus on? What lab test? Do you know, James?
Is that going to be your hemoglobin, which is HB?
Absolutely. Hemoglobin. Exactly. What is the normal hemoglobin for men and women? Do you know the normal levels?
Oh, I cannot remember because I've been normal for so long that I just scan my labs. It's in the middle, and I bypass it. I cannot remember the number.
It's around 13 for men and 12 for women. Okay. So now James is talking about, and I kind of disagree. You're saying that you will not be experiencing symptoms related to kidney disease until stage 5. Probably earlier, probably more like below 30, stage 4. Stage 4 is 15 to 30.
Those ones are just so easy to ignore and
Yeah, of
think
course.
it's like aging or I'm just
Right,
getting
right.
older. That's why I
Yeah,
feel this way.
yeah. I mean, this is classically a silent thing. And, my favorite example of it is one of my employee of the VA who had like 2 or 3% kidney function left and had no idea that he was in kidney failure. Yeah, and his hemoglobin was down to, I think, 5. Normal being 12 to 30. So it's slowly
Oh my
developing,
goodness.
and you
Yeah.
adapt to these things. It's wild.
Yeah.
So you could probably expect with CKD 4 or 5 to definitely have some drop in your hemoglobin. And luckily, we've got a way to treat it. But before you get this treatment, which is called EPO, it's an injection, and it works really good to get your blood count back up. What do you got to check besides your hemoglobin to know whether you should start getting that EPO?
Is it your iron?
Yes, indeed. Yes, indeed, James. You're on it.
Let me
It's
tell you,
called,
I had problems with anemia, and I was so happy when we got it under control.
it's very common and causes you a lot of symptoms: shortness of breath, weakness, tiredness, can get heart trouble, chest pain. I mean, anemia is clearly going to give you symptoms, and it's related to your kidney decline in function. It's called TSAT or transferrin SAT. If you look at your lab sheet, it'll be called TSAT or transferrin SAT. You want that SAT, which means how much of this protein that carries the iron. You need iron to make the hemoglobin in your red cells. You want it to be over 20%. That's what you got to know. Your transferrin SAT needs to be over 20%. And the other lab value for anemia, you know that one, James? You probably hadn't heard of that one. Begins with an F also. It's called ferritin. Ferritin is another lab test which tells you how much iron is being stored in your body. And you want to have enough iron to make the red blood cells. And that level should be over 100, okay? Now, when should you consider, if you're a kidney patient, getting that shot? At what level of hemoglobin? And do you want to get it to normal? If not, why not? That's a few questions.
I do not know the answer to those.
You don't know. Okay. Well, I'm going to tell you.
And I would just be guessing, and I don't want to put a wrong number out there and people to think, oh, that's the number.
Okay. If your number is below 10, you're probably eligible to get that shot. Assuming that the iron studies are normal. You got to get enough iron, otherwise you're not going to make the red blood cells. We don't, and the range that we want to keep that number, that hemoglobin, is in 9 to 11. Not back to normal, not 12 to 13. Because they found, when they try to make it normal in the research, that people had worse outcomes. So the goal is 9 to 11. Let's move on to your electrolytes. That's sometimes called the Chem7, which includes your glucose, your electrolytes, and your BUN and creatinine. What is it? Your fasting glucose should be below 100. And the best way to diagnose if you're diabetic is what lab value?
A1C.
Exactly. Over 6.5, and it's got to be more than one time. If you're over 6.5 more than one time, you may well have diabetes. But don't freak out, especially if you're an older person, and especially if you've got CKD 4 or 5. Be careful. Don't get your diabetes aggressively controlled, because if you do, what's going to happen, James, especially as your kidney function gets worse and you get older? Dangerous thing.
Your blood sugar can drop too low.
Exactly, and
Yes.
it can kill you. It can kill you. Low sugar can kill you. I'm much happier with you having somewhat elevated glucose, because the idea that I want to get my glucose tight and I'm 70 or 80 or whatever, and I've got kidney disease, it ain't going to matter. It's not going to have any long-term effect on your survival. If you're a younger person, you're a type 1 diabetic, by all means, get it tight as you can. Keep it within the normal A1C range. Not for your kidney folks, not for your older folks. The other lab value is something called CO2 on your lab sheet, or bicarbonate. Do you know what that indicates?
The bicarbonate. Well, I know if bicarbonate is below 20, that's when they recommend sodium bicarbonate supplements.
Right.
To get it up.
Somewhere between 20 and 22. So basically, if that bicarbonate on your lab thing is low, you may be eligible to get bicarbonate, and there is at least some thought that could be beneficial to slowing decline of kidney function. The low bicarbonate can, if those of you who are worried about your potassium, ask your doctor, hey, is my bicarbonate normal? Because if that's low, that'll get your potassium up. Things that can cause your bicarbonate to be low are things like what, James? Do you happen to know what gets your bicarbonate down?
I do not know.
Diarrhea. Diarrhea, you lose a lot of bicarbonate. And then there's something called renal tubular acidosis. It's not uncommon. It's a problem with the tubules of the kidney. But there's another lab value, which you go, if you folks are coming along looking at your lab sheet, you're going to see something called Ag. It's the anion gap. And without going into a lot of explanation, it's basically telling you how to interpret that CO2 value, whether you've got an increase or a decrease in that Ag, the anion gap. I'm not going to get into details. It's too complicated. What causes a high CO2, and this is common, your lab value may see the CO2 low. As you get severe kidney failure, you get more acids in your blood. That's a low CO2. A high CO2 means you have more on the alkaline side. And the thing that commonly causes that is a drug that a lot of kidney patients get. And they get it for their blood pressure too. What's the drug that can cause potassium to go down and the bicarbonate on that lab thing to go up?
I do not know which one that is.
Diuretics. Water pills. And that's why we often will give people on a water pill potassium chloride to help with that. Another lab value is your potassium. The normal potassium range is 3.5 to 4.2, and that's in the blood. And how much potassium is in the cell? Massive amounts, about 140. Most of the potassium is in your cell. Potassium is important for your muscles to work, and you
Including
can
your
get
heart.
trouble with the heart and constipation with low potassium. And high potassium can be very dangerous because it can cause your heart to go into fibrillation. As most people with kidney disease say, oh, I got to worry about potassium. Not true. You're equally likely to have high or low potassium. And the things that you may be on can raise potassium, like what drugs that we just kind of mentioned that can raise your potassium.
It was the SGLT2s, correct?
It turns out that the SGLT2s may lower it, but the ACEs and the ARBs for sure, and the aldo antagonists like spironolactone and pleuronone and stuff like that. Another thing that can give you a high potassium is a lot of people say, oh, I don't want to eat a lot of sodium, so I'm going to eat salt substitute. What is in salt substitute?
Oh, potassium.
Potassium.
It's loaded.
Right.
Yeah.
Right. And I'll just briefly mention, I'm a big fan of plant-based diets, and that's high in potassium. And most of you should be on a plant-based diet. I know Jen talks a lot about it. I am a big fan of it. It will help you live longer, decrease your obesity, decrease your stone risk, your cancer risk, much better for you. And how do you know whether you could be on it and whether you need to restrict your K? Lab values. If your lab K is consistently elevated, you may need to start looking at lower your potassium in your diet. Not everybody that has CKD needs to be worried about that. What about your lipids? The lipids, the only lipid value that I think you should emphasize is LDL. The HDL we used to worry about. We wanted to get it higher. The research on that didn't pan out. But anyone with CKD 4 or 5, and anyone that's got protein in the urine, and anyone with real CKD, I'm in favor of being on a lipid drug. Try to get the bad cholesterol below 60. The other lab test is albumin. As I mentioned, albumin is in the blood. It shouldn't get in the urine, but if your kidneys are leaking, that's when you get protein in the urine. And low albumin is a sign of malnutrition. It's made in the liver, and it can indicate liver disease as well. And the last thing I'll mention, because I want to have a little time for questions, is phosphorus and calcium. Phosphorus could go up with kidney disease because the kidney is the thing that controls your blood phosphorus. And as your GFR goes down, the phosphorus is going to go up. Mm-hmm. That's why your parathyroid hormone goes up to get your phosphorus back under control. I think I'm going to stop there because otherwise we won't have any time for questions.
Yeah, we've got about 7 minutes left, and we have so many questions. So all of you out there, if you have a question, type it in right now to the comments, and Dr. Rosansky can see all of them on his side. And you addressed a couple. Someone had asked about the LDL cholesterol, and you had mentioned that, which is great.
Someone had a kidney biopsy, and kidney biopsy, we don't do kidney biopsies normally. We basically make most diagnoses by your history. Like if you've got a long history of diabetes, we call you diabetic kidney disease. If you've got a long history of high blood pressure, we call high blood pressure kidney disease. If you got a lot of protein in the urine, there could be all different kinds of kidney disease, and that's when kidney biopsy is important. Let's see now. Glucose has been kidney transplant. Okay, these are all right. Well, let me see here. You see any that you want to answer? I think we're okay. My GFR was 5. Someone's GFR was 5. I don't know what that. I don't see anything else.
That's right. GRS 5 and creatinine at 1 at 900. Yeah, they did.
Yeah, I don't know. There. Yeah, actually, there's really not that many questions here. It's mostly just greetings. Okay.
So someone asked, well, when they're reading labels, does total carbs include added sugar? And that's a yes. The total carbs includes added sugar. And be careful. No sugar added means no extra sugar. It has all the natural sugar in it.
Someone's asking Woodrow, losartan potassium to work. How much does it reduce proteinuria? Well, look, the thing about losartan is one of the ARBs, just like at ACE, the Prills. I mean, you have to look at your long-term relative amounts of albumin-creatinine ratio to see if it's affecting it. And if you had a lot of protein and you see it go down, it's probably working to slow your decline of kidney function. But it's also important to control blood pressure, because controlling blood pressure is another key factor in keeping your kidneys from declining. Keeping your blood pressure to goal, which is less than 120, 130 or so, is what you all should be shooting for. If somebody's got 2.4, that's high. So John, your 24-hour protein creatinine is 2.4. It's definitely elevated, and you should be on either an ACE or an ARB, probably an SGLT2, and maybe one of the aldo antagonists. GFR is 40, Tiffany, then 64. So this is interesting. Tiffany, it's a great example. You had a 40, then it went to 64, then it's back down to 45. It's very confusing. Do not panic. And I don't know what your age is, but if you're, let's say, my age, you may not have to worry at all. Just keep your eye on it, but also ask your doctor what your protein is. That's the other and probably more important thing to be looking at. Now, again, so Bill has got diabetic 3A and new labs, creatinine, GFR 44. Now, Jardiance is what, James? I don't know brand names. Is that an SGLT2?
Hold on, I think it is an SGLT2. I'll look it up
Yeah.
real quick.
So, Bill, if you, well, first of all, uh, SGLT2s are good for treating diabetes, and they now are the standard. But if your kidney number really went from 60 to 40, rough range in that ballpark, that's about a 30% decline. Okay, and I would follow it before I stop the Jardiance. You should definitely also be on an ACE or an ARB, and I'd really want to know how much protein are in your urine. If you've got a lot of protein in the urine, uh, I would say that the drop, which may be caused by the Jardiance, which is what, James?
It is an it's a Flozin, so it is an SGLT2, correct?
It's an SGLT2, yeah. Yeah, so it could be an initial decline. It could be part of that. And depending upon your urine protein, you got to discuss that with a kidney doc, whether you should continue on it or not. And again, it may just be the variation in these values, and it can often vary quite a bit. Um, Again, people goes 3A to 3B, Chandler, exactly what we've been talking about. GFR 23 back up to 40. Again, very typical. Don't panic over one value. Look at the range, and like Woodrow saying, and look at your proteinuria range and see how that's going. That will give you a good idea of what's going on with your kidneys and what to expect. Uh, and Yeah, somebody here is on Ramipril 5. One of the things I want to emphasize, the ACEs and the ARBs, if you're one of these people that has a lot of protein in the urine, you got to try to be on the maximum dose of the ACE or an ARB that you can tolerate, depending upon how your blood pressure does. That's the recommendation. 5 milligrams is not the maximum dose. So that needs to be further explored.
Yeah, we had a whole show talking about best blood pressure medications and reducing protein that talked about the maximum doses for all the different ones.
And somebody, Ann, is asking about what causes of hardening arteries. This is a normal part of aging. You're going to get cholesterol deposits in the arteries, and there's pretty good evidence that LDL, the low density lipoprotein, has some relationship between the buildup of that plaque in the arteries, and there may be some benefit, especially again for those of you with more advanced kidney disease and significant amount of protein in the urine. Uh, and as CG, type 2 diabetic, heart attack, GFR 17, ejection fraction 15. I'll just say this about EG. Uh, it is not unusual. Now, I generally say try to delay your dialysis as long as possible. And James said 5, but a lot of people can't get down to that level. They may need it sooner because they're symptomatic and their symptoms can't be controlled, without dialysis. You folks like EG with bad heart failure, you may need to get on a machine to control your fluids, and you may be having symptoms. You're having fatigue and vomiting. So it's possible, even with GFR. You said it's 17 in that range. So I've seen people in the 15 range, 10 to 15 range with heart failure that may benefit from going on dialysis. The first thing you want to do is try to manage it medically, taking a lot of water pills. This patient has got a lot of swelling, and if you can't manage it with medicines, then you may need a machine.
Okay, let's
EG
get
has
one
low
more
blood.
in.
EG has a low blood pressure of 80 over 50. That's due to your weak heart. So that's going to make your dialysis challenging, by the way. Now, cystatin C is a better estimate of kidney function. Besides creatinine, there's another marker. It's called cystatin C. It's more expensive, and that's why we don't use it. Your primary care doctor, Karen, should be checking your urine protein. And anyone can do a urine albumin to creatinine ratio. Okay, I think we're.
Matter of fact, all my labs come from my primary care physician.
Yeah, yeah,
My family
yeah.
doctor. I don't get them from the
exactly.
nephrologist.
Yeah, yeah.
Right? I don't go to the nephrologist to get my labs. When I do see a nephrologist, they do labs, but my regulars are all my family doctor.
Last question, Jennifer. GFR mean one kidney is bad or both? If you have abnormal kidney function, it's both kidneys. Now, you can actually have one kidney not functioning and the other kidney can take over, and you can have normal kidney function with just one kidney, which is why you can donate a kidney to someone who needs a kidney transplant. Okay.
All right, Doc, we are out of time. I want to thank you so much for all your time today. This has been a great conversation. I got nearly all the questions right.
You did.
Which is great.
You did great, James. I like it. Very good.
And I want to thank all of you out there watching. Please give the video a thumbs up. And if you can, please subscribe. Less than 20% of people who watch the videos actually subscribe to the channel. And we are so close to 250,000 subscribers, which would be fantastic. And it really doesn't mean anything, but it's a big thing for me to see it keep growing and growing and growing as we're reaching and helping more and more people. It also helps YouTube to recommend this content over the scam videos that are trying to take money from our pockets, promoting fake cures and supplements and stuff like that. And one more plug for Dr. Rowe's book. If you haven't got it yet, fantastic book. Learn the facts about kidney disease. You can find it at Amazon, Barnes & Nobles, your local bookstore can order it for you. Easy to read, very, very helpful. All right, I'm going to go get me a healthy plant-based dinner and get ready to watch tonight's debate.
All right, well, it's going to be interesting.
Yeah, I'm eating a late dinner, so it will be very helpful or healthy, and it will be low in sodium, so I'm not up late at night hitting the bathroom all night long. And Dr. Rowe will be back here next month, plus Jen will be here not next week, but the week after. Jen's our renal dietitian who comes on every month also. And she does a live Q&A. Just come on in and ask questions about diet. All right. Thank you, Dr. Rowe. Have a great rest of your month. Thank you, all of you out there, and have a great rest of your day. And we'll see you all in the next video. Bye, everyone.